We're on.
Hi, everybody. Welcome to the webinar on the report Breaking Barriers, which focuses on removing obstacles to enrollment in health insurance in the ACA. My name is Rinpu Sen. I am the Executive Director of Race Forward, the Center for Racial Justice Innovation, and I'm also a board member of the Alliance for a Just Society, which has led the process of producing this report. We're very excited to have everybody join us for this presentation of the report's outcomes, and we will be running the presentation with three people. They are Gary Delgado, who is with the Alliance for a Just Society and has been the principal person on the research for the report. Dae-Jung Yoon, who is the Executive Director of NACASEC, the National Korean American Service and Education Consortium, which was formed in 1994 at a pivotal political moment for Korean Americans across the country. And by Adrian Barboa, who is the New Mexico Field Director of the organization Forward Together, which works with a multiracial membership of community leaders and organizations to transform both culture and policy to catalyze social change. And the Alliance for a Just Society, of course, is a network that executes regional and national campaigns for economic, racial, and social justice policies and to address inequities in all three areas. So we are going to kick off the presentation with Gary, but before we do that, I want to give people instructions for sending in any questions that you might have for the Q&A portion of this agenda. So for about 25 minutes, Gary, DJ, and Adrian are going to present the findings of the report, and then we have a few minutes to address any questions that might be coming in from the audience. In order to send in your questions, we're going to use the chat function on Google Hangout, and the way you get to that chat function is that you hover your mouse to the left of the screen, along the left edge of your screen. At the very top, there's a blue box with white lines that says chat, and you click on that box, you'll get a chat box, and you'll write in your question, and then I will moderate asking those questions of the three presenters. So I will be looking out for your questions there. So having given people appropriate instruction and talked about what we're doing here, Gary, I am ready to turn it over to you.
Okay, thank you. Good afternoon, everybody. Couple things. What we're going to be doing this afternoon is we're going to be looking at mostly data from a national survey that was conducted by AJS in 10 states over a period of approximately eight months. There were 1,200 people were surveyed in the 10 states, and in addition, we talked to approximately 100 advocates, policy people, and navigators who were attempting to roll out the ACA in their respective states. So we're going to start out by taking a look. If we could get the first slide, Libro. Oh, I can't see the slide. Okay, sorry. Is the first slide up? I can't tell.
It is.
Okay, next slide. So if you look at where we sort of started out, the percentage of U.S. residents who were uninsured in 2013, there were large percentages in communities of color who were uninsured, and there were there were also a large number of whites who were uninsured. The principal kind of question we were asking in terms of this study is, did the rollout actually, benefit communities of color, particularly low-income communities, or did it tend to exacerbate some of the inequities that already existed? Next slide, please. The ACA, as you all know, has a number of espoused goals. The idea of the ACA was to bring the uninsured more fully into the healthcare delivery system, ensure that pre-existing conditions are not a barrier to getting medical insurance, improve access to healthcare providers, spur new approaches to patient well-being and disease prevention, attack racial disparities in healthcare, and hold providers accountable with respect to cost. Now, those goals are all important goals, and a lot of us who worked to get the ACA through were hoping that we were going to be able to look at a program that was going to actually be able to benefit large numbers of people of color around the country. Next slide, please. But in order to achieve the program goals, the architects of the program expanded the bureaucratic infrastructure within Department of Health and Human Services. They built an electronic infrastructure for enrollment, and they relied on key components of existing infrastructure. So they relied on state governmental structures, public and private networks of individual physicians, hospitals, health clinics, and of course, insurance companies. So what you had was a set of good ideas that was built on a system, next slide please, that was built on a system that already had some baked-in inequities. So many of these structures already disadvantaged people of color. So the major mechanism for signing people up was the internet. And the internet is also becoming the major tool for ongoing communications with insurers and providers. In our study, 56% of people of color versus 64% of whites had email, and 55% of people of color versus 77% of whites had internet at home. So we start out in this effort, in this race behind the 8 ball because of an existing condition, an existing structural condition. The fact that people of color had less access to internet than whites put people of color it was less easy for people of color to be able to sign up. And we're going to talk about some of those enrollment difficulties in just a minute. The second thing that was an important structural barrier was that the southern states with the largest percentage of uninsured African Americans and Latinos opted to reject Medicaid expansion, stranding 2.2 million people of color in the Medicaid coverage gap. So the same southern states that had banded together to form the Confederacy, with the exception of Arkansas, all rejected Medicaid expansion. And in many states, people made too much money to qualify for Medicaid, but too little to qualify for the ACA supplements, and many were then unable to get insurance. Next slide, please. The third factor is that currently 20% of Americans live in areas with too few primary care doctors. Our survey found that 19.4% of whites and 34.6% of people of color did not get urgent care as soon as they thought they needed it. Now, the whole question of a doctor shortage is a national question, It's something that lots of people are looking at and lots of people are talking about. But to set up a program, to set up an infrastructure where there is very little that's done about the shortages that already exist, mean that in the coverage to care, part of the ACA, it's going to exacerbate some difficulties. So when we look at the enrollment in 2014, this is as of the first enrollment period, which ended in April 2014, we see that whites were 63% of those enrolled, and there were smaller percentages, much smaller percentages, obviously, of Latinos, African Americans, people of mixed race, in general, people of color. The constituency that had the largest percentage of unemployed people were Latinos. The estimates there are estimates that range as high as 35% of Latinos that were uninsured, but only 10% of the people who were enrolled in the ACA were Latino. In terms of the survey that we did, the percentages that we found were much smaller than the percentages that are being reported nationally for people who are insured, because the latest figures seem to indicate that only 12% of people in the country remain medically uninsured. Because the survey we did focused on low-income communities, the surveys were done at food banks, at homeless shelters, at health clinics, where many people couldn't qualify for health insurance. Our figures are much lower. So the average number of people, percentage of people that we surveyed was only 64%. And the highest percentage of people, and this is consistent with national data, were Native Hawaiians and API people who had the highest percentage of folks who were enrolled. Of the people, however, who obtained their coverage within the previous 12 months, the numbers were actually quite low. African Americans, 29%. Latinos actually fairly good in this survey, 61%. And whites, 35.2%. So of the 1,200 people that we talked to, 40% of them gained their insurance in the last 12 months, which is a fairly low percentage, and looking at an even lower percentage of people who were enrolled of the people that we talked with, somewhere in the neighborhood of 75%. So I'm now going to turn it over to Adrian to talk a little bit about what kind of enrollment happened in the state of New Mexico.
Thank you, Gary. Can everybody hear me okay?
Yes.
Great, thank you. So, yes, enrollment was definitely a problem. As folks may or may not know, New Mexico is the 5th largest state in mass. So
I'm sorry, we're getting echo on you, and I'm wondering if you might have a headset. Try again.
I'm hearing echo too. Let me try this. How is that? Still echoing, right?
Okay. I'm assuming Adrian's getting a headset and we'll be back on shortly. Yep. Here she comes.
So I have a headset. Can you hear me now? Hello? Yes? Okay, great. So enrollment in New Mexico, I think what happened a lot in parts of the state is that although we had Medicaid expansion, that doesn't mean that we were enrolling people. Specifically, rural communities, low-income communities of color were left out a lot in the enrollment process. The state didn't have a good plan for how they were doing outreach or enrollment. They just sort of gave out money mostly to the more metropolitan areas like Albuquerque. The hard-to-reach places had little to no access to be able to enroll. This process never provided a proactive message about enrollment, and really media was not doing much to get the assistance out, to get the work out. There were community groups that were doing enrollment, which we saw sort of the most success in reaching low-income communities of color. But there was this sort of unlevel playing field between folks who were brokers and community groups that were trying to do enrollment, where literally the folks, the brokers, because there was this weird incentive plan that gave incentives to the number of people that you enrolled. So what the brokers ended up doing was coming to these big community health fairs, enrolling folks, but when they would get people up, they were literally screening them first, and if it seemed like their enrollment process was going to take longer, they would let those folks go on, move them down the list, and send them off to one of the community groups, and then they would take sort of the easier, faster to enroll folks, which really what that meant is that our community groups were then not getting the same kind of compensation because they were taking sometimes a whole day to finish out a process, because folks that had 5 people in their family, or maybe mixed immigration, or a certificate of Indian blood status, there was, all these different things that made some applications much harder and much more lengthy, and so then they weren't getting the same kind of compensation for their work as brokers who were sort of moving along and trying to pick the easy subjects. But that's just like an example of the ways that the disparities happened, the way our communities, specifically rural communities, were left out of the enrollment picture in a really big way.
Great, thank you so much. So let's turn to DJ. DJ, you ready to go?
DJ?
We don't have sound on you, DJ. Okay, we'll come back to DJ when DJ comes back. Gary, I'm thinking maybe you should go into your next portion, unless DJ's ready to go, which he looks like he is.
Yeah, it looks like he's back.
Go ahead, DJ. Not getting sound.
Can you try without the headset?
Yeah. So, DJ, we're saying you should try without your headset. Let's see if we get your sound. No sound. Right? Yeah, DJ's talking, but I think we're not. So I'm going to suggest we go to Gary while Libero troubleshoot with DJ. Yeah?
Okay. Okay. So, in general, as I'm sure many of you know, people found the enrollment process somewhat or very difficult. 28.5% of people in general, interestingly, whites more than people of color for the most part, found the process difficult, but everybody had problems with the enrollment. And the problems with the enrollment were varied. So, next slide, please.
Mm-hmm.
So the major thing that people had as the biggest problem with enrollment was the cost of insurance options and premiums. The cost was the biggest problem. This is a finding that we had in our survey. It's a finding that Kaiser has had. It's a finding actually pretty much across the country. Every single survey that's been done finds that cost is the biggest barrier to people being able to get insurance of people who have applied. In addition, there are language issues. One of the language issues that DJ was going to talk about, and we're hoping we can get him back to talk about them. Were the language issues, particularly in the API community. In California, the translation in Spanish finally did get done, but for Native American or API folks, there were tremendous problems around being able to get materials translated and get translated. Now, the figures that Libro just popped on the screen, those are not just California figures; those are national figures. So, in the API community, as well as in the Latino community, but more so in the API community, people were unable to enroll in their own language if their first language was not English. Next slide, please. The other issue which came up, and it came up in every single state, was the fear factor. People were afraid to enroll because they were afraid they might expose undocumented family members, and many of those families just stayed away. Here in California, Covered California sent out notices claiming that people would not be harassed by the migra if they enrolled, but they also there were many difficulties here in California. The ID Verify system, which was based on people's credit scores, was not multilingual, and there was a little fight with HHS to force them to actually get the system so it worked in a variety of languages. So you had a system that was not set up for people who were sort of not more middle class, that was doing E-Verify, and then on top of that, it was not multilingual. Next slide, please. One of the big barriers that we talked about earlier was the barrier to email and internet, and these figures, again, are consistent with a number of other surveys that look at internet, except for one thing. The internet access in these communities is actually lower. The gap is the same between whites and people of color, but internet access is lower for most people that we've interviewed. If you look here, email addresses and internet at home for African Americans was under 50%. For Latinos, it was 33% for email and 41% for internet. Those kinds of responses are even lower than the national averages for these kinds of figures. Next slide, please. The other thing, aside from the pure technological barriers, were the literacy barriers, because the plans were very complicated. In some states, there were 3 or 4 different options. People were not familiar with terms like copay and deductible, and so the kind of literacy that people who are familiar with insurance have was not really available in many of these low-income communities. And when you added to that the technology problem, it made the enrollment process that much more complex. Next slide, please. So when we asked people, do you know which services are included in your coverage and which you'll have to pay extra for, if you look at the figures, less than half of the people knew which were included and which they would have to pay extra for. And there is, of course, a racial differential. Whites knew at 55%, and most people of color knew much less than that in terms of what they were going to have to pay for and what they didn't have to pay for. Next slide. Coverage to care. So here we look at respondents who hadn't seen a doctor in more than a year. And this slide is actually backwards. The percentages of people who had not seen doctors more than a year, we should probably go to the next slide. That slide is actually backwards. The other question we asked is almost a quarter of all is the question of urgent care. If people reported that they needed to be able to see a doctor or within the last 6 months, the question was, did they get the care as soon as they needed it? And the answer was 19.4% of whites and 34% of people of color did not get urgent care when they thought they needed it. One more slide. Oh, no, I'm sorry. Adrian?
Yes.
Sorry.
So we're ready to go back to Adrian. Is that what you're saying? So why don't we, before we do that, get DJ back in first, which means we'll probably need to go back to the last minutes, but try it and see if it works. Can you start us on your stuff?
Hi, can you hear me?
Yes, we can hear you.
Okay. Gary, do you want me to talk about the Cover California, or do you want to talk about the primary care issue? Let me just say briefly about what happened in California. For California, 21% of Cover California's enrollees were Native Hawaiian and Asian American Pacific Islanders. And in our California survey, 6 in 10 API respondents were new enrollees. However, while the percentage of new enrollees was pretty good, there were problems. Our organization found that although the Cover California site claims materials in 17 different languages, the materials available in each language is not the same. Most languages have the application, but not necessarily the supporting or explanatory document. And if we need help over the phone, sometimes we get someone who is knowledgeable, and other time we talk to someone who do not know anything about it. And we have to start all over with a new person. It is very time consuming. In addition, there were members of our communities who were undocumented and afraid that enrollment could jeopardize themselves or their families. Even for legal residents, the system was not easy to get through. The IED E-Verify system was set up for middle-class people with pretty standard and credit profile. If you have to submit document, you can wait days for a reply. And if you do not get verified, the process is even longer. And if you can add translation, the enrollment can take weeks and months. This was not an immigrant-friendly process, even if you have a papers.
Mm-hmm. And DJ, I'm going to ask you to just go ahead and do your next portion on the docs too, if you don't mind. We might as well while you're going.
Oh, you want me to go first?
Yeah, go ahead. And
okay,
then
I think this
next.
This is about the situation where we have many enrollees, but there is a very limited access to see a primary doctor. In our survey, only 12% of API respondents regularly use an individual physician for primary care, and 88%, close to 90%, use a health or hospital clinic. The California Healthcare Foundation recently issues a report showing only 35 to 45 primary care physicians per 100,000 medical enrollees. For us, the problem is very severe and is very simple. There is not many primary doctors who provide language assistance to limited English proficient immigrant patients. But also we see that many times the primary doctor, they refuse medical enrollee because they get so little reimbursement rate from the state government. Because of that, our low-income seniors, they wait 2-3 months to see a doctor just to get a basic checkup. In our Koreatown, Los Angeles, we know that there are only about 29 primary doctors who are accepting medical enrollee, while there are about more than 20,000 low-income seniors. So whenever we register a person in that program, we would call up and see if we could get the person seen as a new patient. Getting people insurance is so good, but it has presented real challenge in getting primary care because they do not get treatment. That's the whole situation here. Thank you.
Thank you so much, DJ. Adrian, do you want to come back in and talk about costs a bit? And then we'll have Gary wrap up.
Yeah, so, in New Mexico, of our survey done here with over 200 people from across the state, 8 out of 10 people said that they cited costs as the important consideration, the thing that they were most worried about in considering healthcare. But then also, in addition to that, people were unhappy with what unaffordable healthcare, and that we have some awesome stories that, well, they're not actually awesome stories, they're pretty sad stories about people having to choose between medication and their food. They said, like this story, sometimes deciding between medication and food. I can get food in other ways, like going to the food pantry, but if my care and medication is not covered in my plan, I have to figure out how to pay the bill. So people are saying their medications were way more than what they could afford on top of paying their monthly co-payments. I have been told that receiving a bill for $348 for medical supplies, I don't know how to pay this bill, and I'll still be able to pay my lights and utilities. I only get $267 a month from my pension. So, in a state like New Mexico, where we're one of the poorest states in the country, people aren't seeing the Affordable Care exactly being affordable for them. That was the number one reason that people cited as a barrier to them getting their access to. I think I just want to also talk a little bit about the literacy part and how over 50% of our surveyed folks had ever shopped for insurance before. So that piece of not having ever been through that process before, the language that Gary already talked about, on top of the fears for cost, and we know now coming down with either penalties through the tax problems, those are all stacked up against our families, specifically rural communities, Native American and Latino families across our state.
Mm-hmm. Thank you. All right, Gary. Oh, TJ, are you continuing? No. Gary, will you wrap us up? I don't yet have any questions, but folks in the audience, you should put your questions into that chat box, and if there are any, we'll address them as soon as Gary has wrapped.
Okay. So a couple of things. Excuse me, my voice is going. There was a mistaken slide, so I just want to sort of correct it. We actually there was a question about where do you go for your regular medical care, and there were a number of answers, including doctors, clinics, etc. But a total of almost 23% of the people that answered had no regular place to go. So they either went to the ER or they simply had no medical home. And again, as in most of the responses that we have in the survey, there's a racial differential between whites and people of color. So that's not to suggest that the ACA could have fixed that gap in the period since it started, but it is to suggest that the gap does exist, and as we sign more and more people up, unless there's some changes to the infrastructure that they're signing people up to, the gap between whites and people of color in terms of access to health care is actually going to get greater. So now to talk about some of the recommendations, obviously expanding Medicaid is the big one, because it would allow people who are 133% above the poverty rate to be able to qualify for medical assistance. To strengthen and enforce language access, in establishing a right to enroll in an enrollee's primary language, streamlining the enrollment process. Some states, particularly California and New York, have already gone after people who are receiving need-based benefits like SNAP or WIC. That practice could be replicated around the country in a variety of states. The ACA also has a special provision. They actually grant money to insurance companies to reduce racial disparities. There currently is not any way for them to monitor that. So although there's supposed to be, so there was some consciousness about reducing disparities, but there's not any program that actually addresses it. Next slide, please.
Gary, I'm going to go in one of the questions that came in from the audience. Relevant here. So someone asked for provisions in the ACA for more reimbursement for limited English proficiency communities. So, in the whether it's in the money for addressing racial disparities or separately, is there an actual accounting for extra money required in reimbursement to states to meet the needs of non-English speakers or limited English speakers? You have to unmute Gary Libero.
Sorry, Gary, hold on a second. I can't unmute you for some reason.
While Libero's unmuting Gary, let me just say a couple other questions in case Adrian and DJ can handle them. One is, what was the sample size for each state? And okay, Gary, go ahead.
Hello?
Yep. we can hear you.
Okay. Different states allocated the money for ACA enrollment in different ways. So, should the ACA be able to monitor how states allocated their monies? Yes, but states made different decisions. So, for instance, in some states where there are large native populations, they contracted directly with the tribes to be able to do enrollment, and in some states they didn't. So those were decisions that were made at the state level. Again, it's an infrastructure question based on priorities that were set forth by the states. So there's not a separate pot of money, as far as I know, for recruitment and enrollment of people who have different languages.
Okay, and just a couple of quick things. Question about what the standard for each state was. A fast answer to that.
Yeah, they ranged. The lowest number was 115. The highest was 179, and they all sort of ranged in. They were all in that range.
Okay. And last question I'll put out. Adrian, you might get on this one as well. The question was, how can we expand the role of navigators? Navigators to improve the provision of care. Is that possible to do? Any relation of that question?
I'm so sorry. You're echoing so much I can't understand. Gary, can you mute yourself?
Sure.
It's at the top.
Yeah. So, Adrian, are you going to take that question, maybe, I hope?
If you could repeat it, because I couldn't understand anything.
So the question is, how can we expand the role of healthcare navigators to improve the provision of care?
So that's a great question. Thank you. That's sort of where we're focusing our efforts moving forward, is really to highlight the way I was talking earlier about, decreasing that incentive that we're, addressing our health exchange board about that sort of crazy incentive that actually gives brokers, more leverage to move faster and actually hurts our community groups who are getting paid less and later in the process. So the way I talked about both internet shortage, the fact that literacy rate, we want to see, we know that the community groups that have been doing enrollment have had a much better success rate at actually helping walk through the people who are enrolling into not just what enrollment looks like, but like what are their next steps on getting their first appointment, what is the difference, taking the time to explain what is the difference between a deductible and copay, and what does it mean when you're going to get your bills for your medication separate from what your copay might be. So that is the way we really see for a state like New Mexico to be able to have true healthcare access, would be that if we can expand the role of the healthcare guides, navigators, whatever you're calling them in your state, would be to really help, which would mean increased language access, increased access for people who don't have internet, and it would help folks through the process of actually accessing the healthcare that they're now enrolling in.
Okay, great. Thank you. Those are all the questions I have. So, Gary, I'm going to kick it back to you. Libero, please unmute Gary to wrap us up. I had stopped you before you did the last slide or two. So if you want to do those, we can then conclude on that note and celebrate the great information that this report gets. And begin work on recommendations or reality.
So, Adrian actually just underscored the expand and extend the role of navigators, which is one of the recommendations. And the first question speaks to the question about measuring results, requiring plans to track health outcomes disaggregated by race, ethnicity, language, gender, disability, and sexual orientation. They've got to count. They've got to count. One of the biggest problems that we've had in actually comparing the data we found with the national data is that in the first reporting period, there were some states where 30% of the folks who were enrolled didn't have a racial designation. So it was very difficult to tell what they actually did in those states. Final slide. So in terms of really improving what can be done on the ground to sort of attempt to address some of the structural inequities, we're talking about ensuring that patients can see a doctor. If people sign up for the program, one of the things that we found is we would talk to people 6 months in and they hadn't seen a doctor. There's no mechanism currently that ensures that somebody's going to say, okay, you've enrolled, that's good. Let's see if we can get you to a doctor. So we're talking about setting up some standards around how many doctors there are per patient, and B, getting patients to be able to get in and see a provider within a reasonable period of time after they've enrolled. So there is a much longer list of recommendations, but what I've done is I've just kind of underscored the ones that I think are going to be applicable to everyone around the country.
Great, thank you so much. And what should people do if they want to take action, if they want to follow up on this report? Who should they contact? I assume they can get the 3 organizations they're related to New Mexico, for example, or really it doesn't matter, right, Adrian? Forward Together, NACASAC, Alliance, national organizations. So wherever you are, you could get in touch with them. But is there anything else that's like an action point that we want to close out on? Libero, you have to unmute Gary.
Okay. We are, in fact, going to be doing a series of meetings, one of which later on in the year is going to be with HHS to talk about, enforcement of regulations, because there are a lot of good ideas around the ACA, but the devil's in the details. If the regulations are not enforced, then people are not going to get health care.
All right, great. Thank you. Thank you again to the Alliance, to NACASAC, to Forward Together, for all of your hard work on this study and for your presentation to us. And thanks to everyone out in the world who joined us and hung in for through our technical issues and time questions. And have a wonderful day, and let's get to work making sure that everybody gets the quality of health care that they need and deserve. Thank you so much. Bye.
Thank you.